Good evening to everybody, and I appreciate your coming on a Friday evening, especially those of you all who are planning a long weekend. So, today we are going to have an interesting presentation by Dr. Mohammed Ansari, who is sharing his experiences about a very rare case. Dr. Mohammed Ansari is a PhD. He is a managerial expert. He runs his own setup in Dhanbad, which is in Jharkhand, and it it actually takes a fair amount of guts to have your independent practice, and even more so if you go away from major metros, and so we appreciate that. Uh, we have as a guest Dr. Rao. Can I have your image
Well,
on face?
thank you, sir. It's an honor to be here.
So Dr. Ashish is a young, brilliant otolaryngologist with vast experience, not only in vertigo, but in fields like allergy. He's a second generation clinician who helps his family practice, who is getting more and more interested in the field of vertigo. And we welcome him as a discussant and an expert in this meeting.
Thank you, sir.
Right. So I am an old friend of everybody. I'm friendly with everybody and old, and therefore I call myself an old friend. So I think without much ado, we will start with the presentation. Dr. Mohammed, you could start with your presentation now.
Yes.
You can put it on slideshow mode. Yeah. Go ahead. The stage is yours.
Yes, sir. Thank you. Thank you very much. Thank you very much, sir. Good evening, everyone. Giving this platform to share my clinical experience. Today I am going to present anterior inferior cerebellar artery stroke. So bear with me and let us start the case study of AICA. The cerebellum receives blood supply from three pairs of arteries, one of the being the anterior inferior cerebellar artery. It rises from the basilar artery on each side of the brain in the junction between the medulla oblongata and the bones in the brain stem. 1 second, sir. There is this. I think. The anterior inferior cerebellar artery is responsible for carries blood to the cerebellum. This area of the brain is responsible for balance, coordination, sensation of the face and body, movement of the face, sense of body position and midline, hearing and eye movement coordination. Dizziness or vertigo, nausea, instability with the pull to one side to sensation, facial weakness and the numbness on the side to diminished body sensation on the other. Hearing loss and the ringing sound in the ear, like tinnitus, you can say, and difficulty walking are the sign of this type of stroke. There may also be trouble seen clearly. Coordination may be impaired as well. First case study, demographic detail is there. Patient name due to technical issues I'm not sharing. Is a 54-year-old patient, male. The clinical history patient came with the complaint of sudden onset of dizziness and reduced hearing sensitivity along with ringing sensation, like tinnitus in the ear from past 15 days. I'm presenting now the VNG findings of this patient. Now we can see in the screen the Saccad's findings. Saccad's, there is a pre-existing vestibular nystagmus was seen only in rightward direction horizontal saccades. See the eye movement on the screen. And next, smooth pursuit. Smooth pursuit is in vertical and horizontal, both are little saccadic pattern. Saccadic. The video is this is horizontal and this is vertical. Both are playing the same time simultaneously. Next is optokinetic response were not preserved in all directions. Next slide, please. The subject had right pitting nystagmus is spontaneous in light and dark test. Post high frequency head shake and post hyperventilation test is there. The nystagmus in the spontaneous light is see here, and the spontaneous in dark is next, that bottom one. Next, the gaze test. Left and down beating nystagmus is seen in left gaze test. Right and down beating nystagmus is seen in right gaze test. This is right, this is left. Now, in terms of Dixel pike positional test, then the right and left, both is a right beating nystagmus. The left side is also right beating nystagmus. Both side Dixel pike test, left and down beating nystagmus in the left side. This is head impulse test. Sorry, head position test. Your right. Your right. This is very interesting. Very interesting. Your right, in your right head position test, left and down beating nystagmus is seen. We can see in the screen. Next, your left, please. Yeah, your left. In your left also, there's a your left head position test. Right and down beating nystagmus is seen. The video, please. Directional changing nystagmus. Roll right, even in roll right head position test, in roll right head position test, left and down beating nystagmus is seen in this patient. See the video. Even roll left. The subjective visual vertical test is within normal limit. The impression is pre-existing nystagmus in saccades, saccadic pursuit, saccadic smooth pursuit, and the right-witting nystagmus is seen in spontaneous light and dark. Pre-existing right-witting nystagmus in head, sake, and the hyperventilation test. Side pocket nystagmus in left and right gaze test. This is little interesting. Directional changing nystagmus is in positional test like your left and your right. We seen in our video, the patient VNG video.
So that is.
Thank you, sir. This is my finding with this patient.
Okay. Okay. Can you tell us anything more about the patient's progress after he left you? What happened to him, or could you share something?
The patient came to me and with severe vertigo, with walking inability little, and patient is consulted the neurologist. Even he treated, and after that he referred to me for the BNG test. Okay. During BNG test, I found these findings. I have shared whatever in slides in my presentation, and now patient is getting benefited from this whatever the medicine prescribed by the neurologist, concerned neurologist. Now he is quite happy. Not we can say in the 90%, but at least 70% relief from
roughly what is the duration between his presentation and you're doing the VNG, and approximately the VNG and today, how much time has elapsed?
Timing is only 15 days, sir. 13 days.
He came to present it, and then he came to you in 15 days.
Yes.
Or, after your procedure, it is now 15 days. What is the... When did you do this?
Patient came to me in 16, 13 of November.
Okay.
I have tested this patient. Okay. I have done BNG in 13th of November. 13th of November.
And so it's about 10 days.
As I, regarding this case, as I concerned neurologist, I have discussed with concerned neurologist.
Yeah.
With regarding this patient, according to the VNG findings and whatever the result he had with the neurologist and the MRI and CT, neurologist shared me, we came to conclusion that in a conclusion we can say that this is the case of AICA stroke. So as per his findings in MRI and CT scan, whatever the clinical details he has, and as far my concern, the VNG reports is there. We present recently.
I know. I think
we came to know that in conclusion with our experiences. Dr. said neurologist. This is, we can say this is the case of AICA.
Good. So I think I'm very impressed. I must thank you. I must congratulate you. You have...
Okay, sir. Thank you. Thank you very much.
You have recorded and you have kept it, and I invite you to keep this, because I think we should start collecting more and more such classical findings so that we can make a kind of library of these kind of findings. That will be very interesting. But
yes,
now to open up the discussion, may I invite Dr. Rao to give us, to come in. I would love to see your face on screen, Dr. Rao.
Yes, sir.
Yeah.
Yes,
so Ashish, here's the question to you.
Yes.
Could you enlighten all of us on what exactly does the cerebellum do in the brain? You know, the posterior circulation of the brain takes care of the brain stem, the pons, and those areas which are slightly the lower part of the brain, not the higher functions of the brain. And the cerebellum plays a unique role. So could you share with us your experience or your knowledge about this area?
Yes, sir. Cerebellum is a very, very important part of our brain, which is very closely related to our field. So it really helps in maintenance of the balance and the posture of the body, as per se, and it helps in maintaining the posture and adjusting the body movement according to the postural changes. That is the most important part. Few
Right.
studies have also shown that it helps in coordination of movements and coordination of eye as well. And a lesser known function of our cerebellum is that it helps in thinking and learning as well.
So
Right,
what
sir.
what would you say are the, I mean, in your experience, how often is cerebellar lesions spotted in VNG? In
Sir,
clinical practice, do you find it common or?
sir, overall, when you think as a stroke, brain stroke, these type of lesions rank up to the one of the rarest ones. Means they are maybe less
Yes, sir.
than 4%, or maybe even 3%, I can tell. And this is about the documented studies what are there. There is less than 4% of the strokes are can be attributed to AICA, and it is very, very rare to see in a clinical picture.
Okay. So there is some question which has come up saying, do you need a VNG to diagnose this or do you need an MRI? So what would you say, Dr. Ashish? What would you think?
Initially, yes, initially, if for diagnosis, yes, non-contrast CT is the initial assessment to be done. Even a MRI is very good, but it takes about 25 to 30 minutes to do the assessment. And I can even say that MR angio is the investigation to go, and VNG as well.
So if I may pitch in here, that basically one would say that to suspect a stroke would be a clinical challenge. It is not that every patient of stroke comes with vertigo. Vertigo as a manifestation is a relatively rare presentation of stroke. Now, stroke generally could be either in the anterior or the posterior parts, depending on the circulation. The anterior is a little more tricky to find because it deals with higher functions. So you may have higher function dysfunction. The posterior sometimes are more acute. So the diagnosis is primarily clinical. Now, those patients of stroke who present with vertigo are the ones who will land up. Like the case which came to Dr. Mohammed Ansari is classically a case who was having unsteadiness and all that, which is why he was sent for that investigation. But a vast majority of stroke patients would not have any vertigo or vertiginous illnesses. So I hope that answers the question. Would you like to contribute anything else, Ashish, or shall I go into a little bit of lecture mode and then open up to the audience?
No, sir, you have placed it very beautifully. The patients with vertigo as the symptom, VNG is the investigation to go. But as initial assessment and as a major, other than vertigo, any other symptoms are there, CT, MRI, and MR angio is the way to go for it.
So,
Yeah.
by and large, I mean, now I'm going into a little bit of a lecturing mode in the absence of a neurologist. I could only share with you what is my understanding of it with all its limitations, and then we open it up. So classically, a patient who comes with a stroke is picked up when you do what is known as the hinge test. That is, you do a head impulse test, and actually a normal head impulse test should set off alarm bells that you're actually dealing with an intracranial pathology. You will also have what is known as a test of skew. That means the right eye and the left eye are discoordinate. So if you shut one eye, you'd get a certain kind of nystagmus. If you switch and shuts the other eye, you'll see a disconjugate nystagmus in the other eye. So that is known as a test of skew. So if you have a normal head impulse and you have a test of skew and a nystagmus which is direction changing, as was beautifully shown by Dr. Ansari, these are the things which should make you suspect that you're dealing with an intracranial problem.
Right, sir.
These are the classical findings clinically which you will pick up. And the moment you pick up, generally it is advised, at least for us, to rush the patient to a hospital more better equipped to deal with neurological illness, because whether it is neurological or cardiological, the early phase is the best phase to treat. You may not be able to avoid the trauma, but you can avoid the peripheral, the penumbra, as they say, around that trauma, right? So if the patient had come primarily to you, Dr. Ansari, this is what would have been binding on you. Luckily for you, this patient came from a neurologist, so to that extent, the emergency aspect was taken off your hand. So, but if the patient does come with, so we are talking now of a subset of patients who have vertigo, where you suspect intracranial lesion, the suspicion of stroke should be high. Hospitalization is mandated. And once you hospitalize, you would expect the people in the hospital, or if you're in the hospital, to order some kind of imaging. As correctly pointed out by Dr. Ashish here, the first non-contrast CT would help, especially to rule out hemorrhagic stroke. That is quick, fast, and quick diagnosis. Because your strokes could be in turn hemorrhagic or embolic or ischemic. And the treatment for all of them are different. So it is only if you don't get a finding on a CT that, and you strongly suspect stroke, would you push the patient for an MRI. And as he said, an MR angio. And you would also keep one small proviso in mind that the findings in ischemic stroke develop very, very slowly. So if you have a hemorrhagic stroke, it will be picked up immediately. Embolic stroke, you will see a cutoff of blood vessels. But ischemic stroke, the findings develop very slowly, and therefore you may have a MR negative stroke. And that, I think we have seen in previous vertigo grand round, that the VNG is abnormal, but the MRI is negative. Even yesterday, I had a patient where I referred a patient to the neurologist, and he said, no, MRI is negative. I don't think this patient has any problem. So that is something which all of us should keep in mind, that you can have an MRI negative and you can still have a stroke. What we were taught in MBBS days of stroke in evolution, that it is gradually evolving. I would love to hear any questions if they are at this stage. Otherwise, I could tell you all something more about treatment of a stroke. So I would invite questions if there are any from the audience, and I would love to hear any of the audience who are coming in to ask some questions, maybe give some comments also before I proceed the treatment of stroke, and then we'll come back to the VNG findings in stroke just before wrapping up. It's open for questions. If anybody would like to participate, just you could show your hand or you could speak. We'd put you on the video. From which I assume that most people are not used to seeing intracranial problems showing up, but Dr. Munishwar has been very kind. I think he put the first question. Dr. Munishwar, in your experience, why don't you come on screen? We'd love to have you on screen. Who is coordinating this? Could you please put Dr. Munishwar on screen? Hello.
Doctor is on screen. I think his video is on.
Okay, which I'm
Yes,
somehow
sir.
not seeing. Yes, Dr. Munishwar, just in your experience,
Yes, sir. Welcome, sir.
Good evening, sir.
Hi. So, in your experience, because firstly, could you tell us whether you practice? I know, but do you practice in a metropolitan town, or would you call your city
Sir, Tumkur, sir.
tier
Tumkur.
2? So
Tumkur,
that
sir.
would be a tier 2 city.
Yes, sir. Tier 2 or Tier 3, sir.
Okay.
Tier 2 is like Mangalore and Belgaum, we can tell Tier 2. So ours is tier 3, sir.
Okay. So, in your experience, how often do patients of stroke come to an ENT?
Sir, not very often, sir. Oh, after the stroke we get. Some patients after the stroke we get. Like patient has a stroke and then they have developed some dizziness and vertigo we are getting.
Okay.
And most of the time we attribute to the intracranial lesions only. We don't. We tell them to go back to the neuro and they'll because central will take some long time to recompensate, and we tell them it will settle down.
Okay.
So and then because compensatory mechanisms will take over and they recover slowly. That's what I tell the patients.
Yeah.
And but the thing is, we don't have ENG, sir. VNG practice I don't do. So I don't have knowledge about VNG much.
So if the people from Cyclops are listening to you, you are already posted a target on your back. But that's fine. But actually, you have now opened up a new chapter that's saying that most of the patients who present with intracranial issues to the ENT are seen after the event. And
Yes, sir, most of
therefore,
the time.
they
But
would fall under the category of needing rehabilitation. So we would actually now come back to Dr. Mohammed Ansari. I will give a small briefing on treatment, and then we'll come back to you, sir, and you can share your experience on rehabilitation. Would that be okay?
Sir, I want to add one point, sir.
Please go ahead.
Sir, actually, I got one patient who presented to me with tinnitus.
Okay.
And later on, after a few months, he came back and told that there was intracranial vascular insufficiency. Means he said he had TIA.
Okay.
He developed one day small like a blackouts.
Okay.
And then he went to neurologist, and then he told the tinnitus was the initial presentation of TIA.
So I think that's interesting because the AICA and the PICA, which are supplying the inner ear,
Yes, sir.
they also supply the roots which are coming out of the brain.
Yes, sir. The cochlear nucleus.
So
The
cochlear
maybe
nucleus and the
maybe at the
roots,
level
and
of
therefore there's an overlap. I think you said
cochlear
it.
nucleus, sir, cochlear nuclear level, it may be affecting. So whenever elderly patients are complaining of tinnitus, we have to think even about the vascular lesions of the intracranial vascular pathologies.
Yes. So I think there is also a case for using aspirin in most patients after the age of 40 or 50, especially
Yes,
if they come up with these kind of symptoms which could be protean. Because if you were to ask for an MRI of every case of tinnitus, maybe it might work in the employed in IT crowd, but I'm sure the villagers would be suspicious of you if you start asking for MRI in every case of tinnitus.
no, but to rule out any major pathologies, sometimes we do it, sir. May not be in the first visit, maybe in the second or third visit.
Yes, sir. Maybe if it is paired with some other symptoms like numbness or weakness with tinnitus, I think so. That is we can go ahead with the MRI or CT.
Yeah,
Then
but
we
I
have
think
more to.
yeah. So Dr. Munishwar has actually thrown a bit of a googly when he said TIA, because almost anything and everything could be TIA.
Yes, sir. Yes, sir. Yes, sir. Transient ischemic attacks. Yes, sir.
Right? So they always
But
say
that patient had diabetes for more than 15 to 20 years. He was suffering from diabetes.
So
And
the
he was,
index of suspicion.
yes, he is a 60 plus. So that patient means after I have treated him. I said nothing to worry. I had put some this one, ginkgo biloba. I had put it. Then after 3 months or 4 months, he only came back and told me that it was diagnosed as TIA by neurologist.
Good.
And
So
after
that's
he treated him, after he treated with ecosprin, the tinnitus came down.
so that's an interesting aside. Would there be anybody else who would give an opinion? Otherwise, I just give you a brief overlay of how treatment is done in stroke.
Yes, sir.
My
Right,
understanding
sir.
from my
Please
experience
enlighten me.
and my readings. See, if you suspect stroke, obviously you have to investigate, and clinically there are some pointers which mark the territory which is affected. So you need to, of course, document what are the problems, and then you need to try to differentiate in the acute phase whether it is embolic, whether it is hemorrhagic, or whether it is ischemic, because the course of each one of these are different. So that is important, not just stroke as one global thing. And there are certain factors which you should keep in mind while treating. Number one, raise the head so that the venous flow is not obstructing the patient. The venous flow from the brain is helped by a head elevation. Number two, pay careful attention to the blood sugar, because a high sugar can damage, a low sugar can damage. Number three, ensure that hydration is not over or under. Again, both of them can cause problems. Treat any other cause. Say, for instance, the patient has a cardiac problem, throwing out emboli, you have to treat it. Treat any other cause which could aggravate, say, fever, say, infection. Once you have that under control, then you have to monitor the patient to see that the patient doesn't worsen. If the patient worsens, then there is a likelihood that you may require surgery. So surgeries for stroke, including doing intravascular surgery by intervention radiologists or cardiologists, including doing surgery to remove the blood clot or decompress the brain, those are all described. But if the patient does not progress, then medical treatment is adequate. And medical treatment could or is basically based on anticoagulants. Various drugs, various regimes, definitely not to be discussed in this discussion, but remember that anticoagulants use should be carefully monitored, because excessive use of anticoagulant or using anticoagulant in a hemorrhagic stroke could lead to further problems. And then it brings us to the interesting aspect, and we would go back to you, Dr. Mansari, that all these patients are left with some residues, right? It could be in the field of vertigo, it could be in other fields, whether it is difficulty in speaking, difficulty in understanding, difficulty in expression, aphasia, whether it is weakness. All these things would require rehabilitation. And I would ask you to come in and tell us something about how you rehabilitate these cases of post-stroke if they come to you.
Sir, as per my concern, very few patient I have come across. So it is very early to say that
No,
in
you
terms
could
of
you
vertigo
could share
patient.
whatever your experience is. How do you?
Mostly, sir, I rehabilitate BP-PV patients.
Okay.
Yes.
So
In the
you are
whatever
very
the
focused. You're very focused on this. You don't go into the neurologist
yes.
domain. But I think this is something which we would urge you now to start looking at more seriously,
The
because patients of stroke, especially who have this, would have other problems. And since you can
sir, sometimes I do in my clinic like position and a like imbalance patient in the postural imbalance, like sometime BP-PB mostly patient have a instability, so some exercises I have.
So,
ये
so
prescribed
one is of
rehabilitation.
course when you're talking about positional nystagmus, whether you're doing maneuvers or whether you're asking them to do branded Derhoffs at home.
Yes.
But basically, the principle and the reason why I ask you to have a look and ask everybody who treats these patients in the post-stroke setting is that many patients who need, see, rehabilitation is not looked at in India at all. The Indian medical system is very much focused on diagnosing, treating, maybe operating, and then the patient is left to go home and improve on his own. Now, as a matter of fact, we are in a position to advise them and to help them. Leave the financial angle, it would be profitable, of course, if the patient comes back to you. But even without that, if we monitor the patient's improvement in various aspects, all of that helps in resetting his balance. So, my request to everybody who sees such cases is to start thinking about rehabilitation. Now,
Right, sir.
like we talk about vertigo and balance. So consider
Yes,
this as
yes.
part of a balance uh, thrust to get the patient back to balance, because he needs to get back to function. And balance is a very important part of function. So it could be to an extent physiotherapy for muscle building. It could be to an extent, patient getting confidence in doing the natural activities. But we should learn now. I think we should all start pushing, and I'm not getting into preaching mode, but we should all push towards rehabilitation, especially if we see occasional patients of stroke, and gradually you find more and more patients of stroke would start coming to you because there is a dire need among patients. Usually, it lands up with some physiotherapist who does some exercises and leaves it at that. But that is not going to give the patient the sensation of balance, right? So there are many things which I would urge, especially our audiovestibular colleagues who are listening, to think actively of balance rehabilitation as part and parcel of our vertigo treatment. At this stage now, let us sort of go back to the where we started from, which is the uh, lesions in the cerebellum and how they manifest. So I think, Dr. Ashish, would you like to talk a little about cerebellar lesions, or would you want me to bore you further on cerebellar lesions?
Yes, sir. So a little bit about cerebellar lesions. I can just talk little bit.
Please, please.
So usually, as you well put it, sir, the main symptoms will not be dizziness and vertigo. It comes as a subpart of this stroke. So, but a good amount of patients do suffer from vertigo and dizziness, mainly imbalance in the postural aspect and imbalance in the different movements and positioning. And they even have some decreased tactile sensation as well. So, that is also one of the symptoms.
So I think and now moving into slightly summating mode. So the function of the cerebellum is actually to coordinate. If I may sum up the cerebellar action, the reason for a cerebellum is it tries to coordinate all the actions. So part of the coordination is a coordination of the eye, coordination of the vestibular inputs with the eye, the posterior column lesions. So all of these fibers, as they go up, they send branches to the cerebellum. So any problem with the cerebellum usually manifests as lack of coordination. And that is what we are seeing in the VNG. So that is why you will see dysmetria. There is a certain category of these problems which happen because it is intracranial. For instance, you'll have direction changing, which is non-specific to intracranial problems. For instance, you will have the fact that visual fixation cannot alter this nystagmus, which is again classical of intracranial. But what picks out a cerebellar lesion from the other lesion is the fact that, as was beautifully shown in the videos, that overlying a nystagmus, there is a seesaw kind of a pattern. That dysmetric thing is a sign of the fact that the cerebellum is not acting and the coordination of the cerebellum is not active. And from that, you can clinically diagnose that it is the posterior circulation which is affected. And from that, you can further diagnose, depending on the MRI, whether it's the AICA or the PICA, which is, of course, a largely theoretical thing. So I think that could be a simple take home from this meeting, that you have a you have vertigo, which can be caused due to intracranial problems. In intracranial problems, you can further try to localize based on the type of nystagmus, and you should be able to reach a diagnosis. And the last point which he made, that many of these patients require rehabilitation. So to sum it up, I think if we have these as take-home messages, that our index of suspicion should be high. We should, like Dr. Ansari did very well, observe your VNGs carefully, not do it as a routine. And you should follow up your patients and try to complete the circuit so that he comes back to you for rehabilitation. So I think these are adequate take-homes. And I open it for discussion. If anybody wants to share his case, we have another 5 to 10 minutes. I'd be happy to take inputs. I think nowadays, because of road traffic accidents, a lot of patients land up with road traffic accident related intracranial problems, where the diagnosis is fairly simple, but they too would fall under the rehabilitation basket. So I think as ENT and audiologists, we should all make an active attempt to study about these cases, and maybe in future open our doors to getting more and more patients of that category, to find out, who have, like you talked about, tinnitus being a warning signal of something more serious. Vertigo also could be a warning of something serious and gives you an opportunity to rehabilitate. So our role can keep forever increasing. Now,
Tinnitus is a very challenging issue.
Tinnitus is a feature of, I think, another discussion, but it would challenge us for more than an hour if we go into tinnitus discussion. We'll restrict to vertigo here, is my request, and I think I think I'm in danger of putting you all to sleep if I keep talking. So I would request people to start talking a little, or else we would wind up the meeting a little earlier than the allotted time. Open for inputs. Does anybody have any experience of intracranial problems in general, cerebellar problems in particular? So our audience is been lulled to sleep. I think that's not
Dr.
right.
You're on mute, sir.
Who's on mute?
Yes, sir. Sir, these type of patients, hello?
Yeah.
These type of patients, whenever we suspect intracranial,
yeah,
I just take the help of physicians first.
Yes. No, I'm not saying that. I'm not saying we should take over, but even the physician is helpless when it comes to rehabilitation.
Yes, sir.
So I think that's where. I think Dr. Ankit Pathak flashed a message saying that he considers vestibular rehabilitation, VRT. I'm assuming you're talking about VRT goggles, or you're talking about something else, or vestibular rehabilitation in general. Dr. Ankit, would you care to come on screen? We'd be happy to see you. Dr. Ankit? So, yes.
Hello, sir.
Yes, Ankit,
good evening to everyone.
Yeah.
First of all, I would like to introduce myself, that I am an audiologist at BMGMC Sedol, Birsa Munda Medical College Sedol, and I am in a post of clinical audiologist in the ENT department.
Very good.
And I have done my bachelor's from NSCB Medical College Jabalpur, and I was the student of Master in Audiology from All India Institute of Speech and Hearing. And from there, I have gained a little bit of knowledge from Neeraj Kumar Singh sir. And I have very, very less knowledge from all of
No,
you.
but you can share. No, we are all.
You are my like.
No. I don't think anybody is. We are all colleagues here. So please share your experience with.
Okay. Okay, sir. So during my practice in the ENT clinic, there I perform usually assessment part and sometime management part also. So there once I have had one patient with AICA. So for that I had performed VNG, and uh, uh, I have learned that there is some as you told from head impulse test. If there is skew deviation, you can like put this as a query, and for correctly diagnose it, you can advise for the MRI. So I just performed the hint, and I wrote it there like query AICA, and after that I have referred the patient to the neurologist, because firstly it came to the ENT doctor. So after that he underwent a radiological evaluation, and after that the neurological part like the management medication have started. Other than that, I had also recommended him for vestibular rehabilitation therapy. So for that part, his gates were affected. Like the tandem gate, some of the cerebral test I had performed, in which the tandem gate was affected. So for that, I have done some vestibular exercises. Like I have advised him to go for uh, eight, eight walk, figure eight walk. Like you draw the eight number in a chalk, and you ask the patient to walk like that in a eight number. Other than that, he had tinnitus also. For tinnitus was not that continuous, it was intermittent. So for that, I had advised him to go for tinnitus retraining therapy. And other than that, I have also asked him to perform some of the visual tests, like gaze stability test, that how he can gauge and strengthen his VOR, like visual ocular reflex. So for that, there is thumb exercises that he can perform from left to right. So there are several exercises so that we can.
No, that is brilliant, Ankit. Thank you very much for what you contributed. I think you have really, in a sense, told everybody the importance of this. That number one, as you pointed out, if your index of suspicion is high, you can pick up a case, and congratulations that you picked up a case on clinical and vertigo assessment. Good, and even better that you pointed out that we have the expertise to attempt to rehabilitate. The only proviso is that the patient doesn't come back immediately to you. He comes back over a process of time. So I think the call is for us to engage more with the neurologist. So because
Yes.
you will find when you engage with the neurologist, the world is getting so complex. We are happy to have anybody to help. And the neurologist is no different. He's more than happy if you help him out. So I think this is a good message for everybody to take home. That and we now have a comment from Anusha Ankam. Could we have her comment on the board? So Anusha says that with a high index of suspicion, we can pick up stroke like acute vertigo within the critical period where the MRI was negative. Yes, that is what we mentioned, that you have MR negative stroke, which is more common in ischemic strokes. And generally these patients, I mean, they require monitoring and then a repeat of an MRI, by which time it comes up. So basically this is done on clinical assessment. So the patient is, because usually it's very rare to get pure vertigo. You would always have some other CNS manifestations which may have been missed. Definitely missed by us, because we as ENTs and audiologists do not do a detailed neurological examination, though it is written in our books, we don't do it. I'm sure if you were to take a straw poll, very few of us would check for reflexes or do the standard neurological examination. We would restrict to our area. So it is important that we have a high index of suspicion. Very well said, Anusha. Okay, so I think I would thank Dr. Ansari from the bottom of my heart.
Thank you very much,
you
sir.
have done a very, very good job, and
Thank you very much, sir.
Keep contributing, keep attending such meetings, and we will
Thank
get
you
back to
very
you
much, sir. You have enlightened
we will
us.
create a library of
Yes,
such
yes.
videos, and we'd love to have you contribute. It will be acknowledged that it is your patient, and we'd like to create a library for others to benefit. Thank you very much. Dr. Ashish, of course, thank you very much. I think
Thank you so much, sir.
we have got you in your clinic. We can, with all your impressive
Yes, sir.
certificates behind. Though I see something which looks like a whiskey bottle, which is very suspicious. I hope there's
No,
only
sir.
water in it.
Yes, sir.
Okay. So you're off the hook. And thank you for all those who have attended and contributed. So thank you, one and all. I think this has been an enlightening, and I certainly enjoyed presenting. Thank you.
Thank you, sir.
Thank you very much, sir.
So much.
Thank you, Doctor. Thank you, sir.
We will be summarizing this into a small newsletter, which we will circulate. Thank you.
Thank you, sir.
Thank you.
Okay, good night, sir.
Good night.
Good night. Good night. Good night, sir.
Good night, sir.